all hear us. Welcome to Project Echo. We will be talking about how to get results with tobacco cessation and letting you know how you hold the key to success. So again, my name is Kelly Goatley-Seals. I'm with the Washoe County Health District.
And I'm Sandy Wartko with Carson City Health and Human Services, and I'm a public health nurse.
And so we'll jump right in and get started. We have a lot of information to share this afternoon. So I will start out in the first part of the presentation and hand things over to Sandy. What we're going to talk about today is the toll of tobacco here in Nevada as well as nationwide. We're going to talk about e-cigarettes, which have really exploded in use rates, as well as other tobacco products. And then we're going to talk about Medicare access, CHIP reauthorization, and merit-based incentive payment systems, ICD-10 and CPT codes for tobacco, brief intervention, related to tobacco, and our local Nevada quitline resources. So just acknowledging that some folks on the call today may be tobacco users, and so this information comes from a public health background. We are using a non-judgmental approach. If you do work in public health or the healthcare field, just acknowledge that that's generally the way we want to approach this with tobacco users. It's a very difficult habit to break. We want to offer support and encouragement and leave the judgment behind. So I just wanted to acknowledge that as well, that we may have folks on the call today that do use tobacco. So looking at where we are here in Nevada, if you've been in Nevada for a while, you know that before about 10 years ago, we did not have clean indoor air in a lot of our workplaces. So we do have some exempt locations, but we are now celebrating 10 years since the Nevada Clean Indoor Air Act has been passed, and it protects a large proportion of our population from secondhand smoke exposure. More recently, in 2015, in the legislative session, a cigarette tax was passed, $1 a pack, which is significant. And we know both of those approaches, raising the price of cigarettes as well as limiting the use, allows for or promotes decreasing tobacco rates. So though we're definitely on a path where we're trying to make some changes in our community that's going to offer support for those that are trying to quit using tobacco and preventing future use of our youth particularly. So some data, current adult smokers, our rate from our 2014 BRFSS data is about 17% adult smokers, and that is in Nevada. Adults reporting daily smoking is 11.4%. So current use includes both daily use as well as let me see here, some days, so that's a combined number there, but our most recent data for daily use is about 11.4% of our population. So we know that males are more likely to use than females. Our high school prevalence rate is 7.2%, so we've done a great job over the past many years decreasing our youth tobacco rates. I'll draw your attention to the bottom bullet there. 45.8% of those who smoke in Nevada report trying to quit in the last 12 months. And that's really important. A lot of times as public health professionals and as providers, we feel a little nervous about talking to people about quitting. But what the data shows us is that close to half of tobacco users have tried to quit in the past 12 months. Most people do want to try to quit. They're just not always successful with it. So we can keep that statistic in mind when we have the opportunity to talk to somebody about tobacco use and potential cessation. All right, so a few more stats. This isn't a surprise to anybody. We know that tobacco has a significant impact and significant rates on death and disability, both in our community as well as across the United States. We also see that secondhand smoke causes death and disability, and we're not going to talk about it today, but we're even seeing third-hand smoke is detectable in biomarkers and has an impact on health. So even something as far removed as third-hand smoke, which for a quick description might be the toxins left on a tabletop in a room where somebody has been smoking, that is detectable to somebody who doesn't smoke themselves and could have some health impacts. So we know that there are significant impacts from using tobacco and being exposed to tobacco. The cost of tobacco, we have on this slide that the tobacco industry spends $78.7 million each year to market their products in Nevada. We know it costs tobacco users a significant amount of money. In a lifetime, we see the number there, what it's estimated to cost a user. And that number includes the potential monetary loss from purchasing cigarettes, healthcare expenditures, income loss due to illnesses and other reasons. And so when you add all those up, the use to the user is significant as well. The amount of money that we have for tobacco prevention is definitely a fraction of what the tobacco industry spends in our community. So our prevention funds, we try our best to educate and work on policies, but it's an uphill battle when you start looking at the financial impacts and the money that the industry spends in our state and in our communities promoting their products. So looking at the cost of smoking, this could be a potential teachable moment. If you are working with people and you have the opportunity to talk about cessation, they could do the math themselves. With particularly the recent increased cigarette tax, that is more money out of people's pockets, and it's a mechanism to call attention to what other types of funds somebody could spend that money on. So looking over 1 year's time, approximately a pack a day is going to cost somebody well over $2,000. In 20 years, we're looking at just over $47,000. So getting people to think about what that money could be used on may potentially be a motivator. It could be a teachable moment. So looking at smoking and the damage it does on the body, I'm not going to spend a lot of time on this. As providers, public health professionals, we've learned a lot about this, but the general public, when they think about smoking, they think about the lungs, and there's definitely the impact on lungs and the cancer. But if you look on this slide or any type of literature, we see that the damage caused by smoking is significant to the whole body. Cancer causes and links to the stomach, the mouth, the esophagus. That has impact on the cardiovascular system, the heart, the brain with strokes. There at the bottom we see osteoporosis. So again, getting people to realize that it's not just the lungs that are impacted, but significant impacts to the whole body and variety of systems within the body. Specifically looking at the lungs, we're very familiar with the link between smoking and tobacco use, lung cancer, chronic obstructive pulmonary disease, including bronchitis and emphysema, and the smoke damages that alveoli, the small sacs within the lungs. So it's impacting the ability to get oxygen into the body, and it exacerbates asthma. Looking quickly at the cardiovascular system, we know that tobacco use increases blood pressure and heart rate. We know it causes hardening and narrowing of the arteries, and again, it reduces the oxygen that reaches the body's tissue. So there's a couple mechanisms within the lungs and our cardiovascular system that's reducing the oxygen that our tissues depend on. There is a strong physical addiction to tobacco, and we have some information on this slide about the components of that, what is involved, and some of the physical addiction results of that, we have the pleasure, the appetite suppression, reduction of anxiety and tension. What this doesn't talk about is the psychological addiction as well as the physical. And you know, what people experience is that a lot of times the physical addiction can be overcome in a matter of weeks or months, but that psychological addiction, a lot of times people that are longtime tobacco users, using tobacco or smoking becomes, in a sense, part of who they are. They associate it with waking up in the morning, or they associate it with having a meal or driving their car or talking on the phone. And it can be very difficult to break that psychological addiction. So pairing this very strong physical addiction with that psychological addiction is a difficult habit to break. Sandy and I were talking before the presentation, and we've heard it in numerous different ways, that tobacco and nicotine is as addictive as cocaine and heroin. So those same mechanisms in our brains for addiction hold true for nicotine as well. So we'll start moving into secondhand smoke. We know the toxicity of tobacco smoke, but that carries over to secondhand smoke as well. We know that it contains over 7,000 chemicals, 70 of which are known to cause cancer. We have some of that information here on the table, on the slide. This secondhand smoke also leads to death and disability. So we see that caused by the tobacco users themselves, but also those that are exposed to this secondhand smoke experience death and disability due to the toxicity. When we look at children, their exposure is involuntary, which is stated here on this slide. A lot of times children cannot control their exposure. They may be exposed in their homes or in cars where there's really no option for them but to breathe that secondhand smoke. They are particularly susceptible because their immune system is less protective. They breathe in more air relative to their body weight, so the level of toxicity could be higher in children. And we see from the data that those children that live in poverty and households with low levels of educational attainment have higher rates of secondhand smoke exposure. We know that there's no risk-free level of exposure to secondhand smoke that goes both for adults and for children, but particularly for children for those reasons that we spoke about. We know that exposure to secondhand smoke is linked to a variety of illnesses for children and infants, including asthma, respiratory infections, ear infections, SIDS. Smoking during pregnancy, it results in more than 1,000 infant deaths annually. When you look at use among pregnant women, data shows that about 10% of women reported smoking during the last 3 months of their pregnancy. Women who smoked 3 months before pregnancy, of those women, 55% quit during their pregnancy. So this is also a time that can be used as a teachable moment. Women are aware of the damage that could be caused to their children, and they're more motivated to try to quit. So that is a key time as well. Among women who quit smoking during their pregnancy, 40% relapsed within 6 months after delivery. So that continued to support after a woman delivers is important. A lot of data out there if you're interested in more data related to exposure of children and secondhand smoke. So we're going to start moving into some of the different products. Youth here is what we're looking at. 7 out of 10 middle and high school students who currently use tobacco have used flavored products. So we're going to look at several slides with information about what those flavored products are. Here specifically is mentioned e-cigarettes at 63%, hookah at 61%, and flavored cigars at 64%. So these flavored products are very popular among youth. And we've got a short video here. It's actually an ad from California that we're going to show.
We showed these kids some products purchased at a nearby store and asked them what they thought.
Ooh, this is cool. They are the same thing.
What they didn't know is that each one was a tobacco product.
Oh, it's great. I see that right there. Oh, fun. It smells like a... It looks super cool. Ooh, this is pretty. It smells like strawberry. Also, these are my favorite. Blueberries. Animal. Strawberries. Animal. Look at this man.
The tobacco industry spends nearly $1 billion an hour marketing its addictive and deadly products.
Pink is one of my favorite colors.
With brightly colored packaging and fruit and candy flavors that kids love, who do you think they're targeting?
Could I have one? How about we each get two? We get to keep them.
So it's the ad pretty much speaks for itself. It's a good depiction of marketing techniques used by the tobacco industry, and the reality is that they work. The flavors and the colors are a big draw to youth and young people. So we're going to talk a little bit about these products. We call them other tobacco products. They're not combustible cigarettes, but they do deliver tobacco to the body. So basically, other tobacco products refer to any tobacco product that is not a combustible cigarette. So cigars, little cigars and cigarillos, these also come in flavors. So some of these products may be a draw to young adults and youth. They resemble cigarettes. According to the tobacco industry documents, they're intended to replace cigarettes because of some of the restrictions that we see on cigarettes. And so sometimes we can see these cigars used in other ways where cigarettes are prohibited. They do come in flavors, and they can be specifically targeted to particular populations. Dissolvable tobacco products, the top picture there are the orbs, which are mint-sized dissolvables, and you can see them right next to Tic Tacs. We saw in the ad the child asking if they were mints. It's really closely looks like what you would see in a Tic Tac mint. And one of those is you can receive about as much nicotine as in a cigarette. The bottom is a depiction of a strip, similar to a Listerine strip. Again, dissolvable within the mouth to deliver nicotine. There's also sticks that resemble toothpicks that deliver nicotine. A lot of folks may want to use these types of devices, maybe not as their primary nicotine delivery device, but if they are going to be traveling on an airplane and want to have that nicotine delivery. Lower rates of use for these types of products compared.
Have you ever seen those used for smoking cessation?
Question about using these for smoking cessation. They are not approved cessation devices. So I'm sure people are attempting to use them as cessation devices, but they are not FDA approved cessation devices. So they're not something that we recommend, and we don't promote that to users. There are other cessation devices out there that are recommended. Chewing tobacco and snuff, again, there are a variety of different types of chewing tobacco. Snuff, again, lower rates here in Nevada of use of these type of products. The bottom there, bullet, 2.8% of Nevadans surveyed report using smokeless tobacco. There's also something called snus. This is a moist smokeless tobacco. The thing about snus, if you look at the third bullet down there, it does not require the user to spit. So some people can be using this snus product, they have it tucked between their cheek and their gum, they're receiving the nicotine like chewing tobacco, but they don't have to have a container to spit it. So you may even not recognize that they're using this product. Also has negative health impacts. All of these other tobacco products have negative health impacts, but we see that with snus as well. Looking at hookah, this has become more popular over the years. Again, something that young people are drawn to, also known as a water pipe. And a lot of folks have the misperception that it is less harmful than smoking cigarettes and smoking other types of tobacco, and that because it has the water component, that the water somehow filters the smoke before it gets in their body. It's not the case. When you look at some of the data here on the slide, the bottom two bullets, hookah smoke contains 36 times more tar than cigarette smoke. Can fill your body with 8 times more carbon monoxide than smoking. Looking at this next slide, 100 more times the smoke volume compared to a single cigarette. And that's because that when folks are smoking, and smoking in a hookah session is how it's referred to, they take more frequent puffs, they inhale more deeply over a longer period of time. So the exposure during a hookah session is much more intense. And so again, we see that it is considered to be social, that youth are more drawn to using hookah. And here in Nevada, we see that, like national data, more use among the younger populations. So looking at e-cigarettes, again, this is what we've seen really explode in recent years. It's a nicotine delivery device. It's been around for many years, developed in China around the year 2004. When a user puffs on the inhaler, the battery heats the liquid, nicotine into an aerosol, which is brought into the lungs. A lot of times it will contain flavoring, so we'll look at some slides here and see the different types of flavoring and how that plays into this equation, as well as nicotine. There are devices that are labeled saying that there is no nicotine, but what studies have shown is that even those products labeled as no nicotine sometimes will have trace levels. So it's hard to know with the marketing of these. So the top shows more of a older version of an e-cigarette. The bottom looks like something that you're more likely to see now, but the components are generally the same. There's a battery component which heats the nicotine, the liquid nicotine, an atomizer in a tank filled with that liquid nicotine, and some type of mouthpiece for inhalation. And the verbiage and what we call these is important as well, because people, when you're talking about tobacco use or e-cigarette use, sometimes you need to be specific. If you are asking about tobacco use, somebody might not consider these products a tobacco product. So you may have to get specific and refer to them the way that the person is familiar with, as an e-cigarette, an e-cig, a vape pen, an e-hookah. So there's a variety of ways that terminology that is used to refer to e-cigarettes. E-juice. So this, again, using the e-cigarettes, it could be a disposable model, or it can be a model where people refill their device with this e-juice. Usually contains propylene glycol. It contains a lot of times flavoring and the nicotine. A 15 milliliter bottle can be the equivalent of 4 packs of cigarettes. So that can potentially be a draw for people, as well as the price of these e-products, especially with the rising taxes on combustible cigarettes. Sometimes this could be more affordable. Prevalence, we have seen our studies more recently include questions about e-cigarette use, so we have more data now about who is using e-cigarettes and how many. In 2006, we saw that 24.2% of adults had ever tried an e-cigarette, with about 1/5 or 21% believing that they are safer than regular cigarettes. So again, that is a perception that in public health arena we need to work on, letting folks know that these aren't necessarily safer than cigarettes, or we need to educate people about how they're not safe. We can see here some of this commonly cited reasons for people using e-cigarettes, and we see again from our data that youth are using these products, and we're seeing more youth using e-cigarettes when compared to combustible cigarettes. So while we have seen a decrease in youth using combustible cigarettes, with the increase in cigarette use, it really results in no overall change for tobacco use among youth. And the image here is Hello Kitty. So, you know, if there's any question for who these products are targeted to with the marketing and the flavoring, it's really apparent. So talking about that safety and quality, why do we want to give messaging about the safety of these things and maybe break some of those misconceptions about how safe they are? That the FDA has studied some e-cigarettes. They have found carcinogens and heavy metals, both in the juice, the e-juice, as well as the aerosol. Quality control was inconsistent or non-existent, so we're going to see a little bit more about that. They found, again, that some e-cigarettes labeled as nicotine-free did in fact contain levels of nicotine, and the nicotine levels varied. While you may purchase a container of e-liquid that has a certain listing on it for what type of nicotine level it contains, the actual testing of that may show something different. So sometimes as twice as high as what is on the label. And back to the question of a cessation device, these products, while sometimes marketed as a cessation device, or maybe not marketed, but when you go into the store to purchase e-cigarettes, the person behind the counter may talk about how it can be used as a cessation device. It is not recognized as an approved cessation device. It contains nicotine, which is, as we saw, a highly addictive substance. It constricts the blood vessels. It is a vasoconstrictor, and again, like combustible cigarettes, we see that it increases heart rate. It is still considered a neurological toxin. It can be used as an insecticide, so whether it's being ingested into the body from a combustible cigarette or through this aerosolization of the e-juice and the nicotine, the impacts from the nicotine are similar. We have also seen, we'll see it on a slide as well, but the bottom bullet here, when ingested or absorbed through the skin, it can cause vomiting, seizures, or death. The nicotine, in the variety of ways that it's used, whether it's dissolvables in the mouth or smoking or through the skin, it's something that is absorbed very quickly into the body. So here we see the calls to our poison centers. In Nevada, the last data that we received is that 70% of the calls related to children under the age of 15 when it had something to do with the e-nicotine. We saw in the ad the flavors, they're appealing, they smell good, children are drawn to them, and we have seen a significant increase in calls to the poison center here in Nevada related to that. The total number of poisoning calls or poisonings are likely higher than what was reported. The assumption is that not everybody who experiences a exposure was going to call the poison control center. So the assumption is that the exposure to this for children and others is actually higher. And I'm not going to read all the data on there, but you have that available to look into further. Looking at the liquid, this is an image from a store. It's, you have these bottles of flavorings of liquid nicotine, of the components that are used to mix this liquid. It's unregulated, so the sanitation could be questionable. The people that are mixing the products, it's really unsure how much training they have. Are they doing it correctly? What is the process that's being used? So we have a couple pictures here about looking at how these liquids are mixed. Sandy pointed out here to me earlier the fact that this is sitting on a Coca-Cola, some type of Coca-Cola shelving. So again, pointing out the unregulated nature of this. You've got chemicals very close to food and food products. So how is this being managed? Because it's unregulated, we really don't know. There was a very interesting study that came out recently. A group from DRI has been giving a couple different presentations here in Northern Nevada, and they have a study. The reference is at the bottom if you want to take a look at the study, but we see these flavorings and the questions about this aerosol. How harmful is it? And again, from our local Nevada Desert Research Institute, they specifically looked at the flavoring compounds and what happened when those flavoring compounds were heated. And a common thing that you'll hear from the tobacco or the e-cig industry is that all of these products are FDA approved. Well, they are approved a lot of times for ingestion as a food product or as a flavoring to be consumed in digestion, not necessarily approved for inhalation. So there's very much a need for looking at these products and what happens when they are heated to high temperatures and inhaled into our lungs. What this study found was that they reviewed studies and looking at that propylene glycol and the glycerol, and then in this study that the thermal decomposition of those flavoring compounds of e-cigarettes dominates formation of aldehydes during vaping. So we know that aldehydes are dangerous, they're cancer causers, and the levels of aldehydes were significant in the e-cigarette aerosol just due to the flavorings, not even looking particularly at those other components. So I encourage you to take a closer look at this study. Secondhand aerosol is another area that needs to be studied more, but we do have some data on this. We know that it's not just harmless wider vapor. If you notice that I'm referring to this as an aerosol, when we refer to it as a vapor, sometimes it's interpreted as water vapor or harmless. So we really want to get the message across that it's not a harmless water vapor, it's an aerosol, and it does contain components that could be harmful, including nicotine, small particles, ultrafine particles that have low levels of toxins that we know cause cancer. So exposure to those may exacerbate respiratory ailments like asthma, constrict arteries like we see with exposure to nicotine, and we know that there's at least 10 chemicals identified in e-cigarettes that are classified as carcinogens and reproductive toxins. Propylene glycol was mentioned. That is used as a base in e-cigarettes, one of the primary components in the aerosol emitted by e-cigarettes. There is some data on the short-term exposure of that propylene glycol, including eye, throat, and airway irritation. The long-term exposure as an inhalant is unknown. Again, something that is approved by FDA for consumption in other means, but not necessarily for inhalation. Even again, so that's the bottom bullet there. Marketing, I'm going to move quickly through this. I want to make sure I leave Sandy enough time to share the information she's going to share. But the marketing for e-cigarettes, it takes the same path that the traditional tobacco products have been using. They are promoted heavily online. Again, promoted as nicotine replacement therapy, and they're concerned, it's a concern because it renormalizes smoking, especially with its targeting to youth and the youth exposure. E-hookahs, basically, if you've heard of e-hookahs, they're basically e-cigarettes. Hookah, as we said, has a perception that it's healthier, so the industry using that perception of e-hookah to again give the idea that this is a healthier product or a less dangerous product. Mods, the slide that we looked at before, from the more traditional e-cigarette to what we're seeing now, and these what are referred to as mods. They can be individualized, they can be big, they can be small, they can have bling, and it really appeals again to youth and young adults and people that want to individualize their use of this product. So may not look anything like what we saw a couple slides ago. You may be seeing these big boxes, and some of them can create a lot of heat within them to aerosolize that liquid vapor. So questionable how that impacts the user's health and exposure as well. Just wanted to quickly point out that tobacco isn't the only, or nicotine isn't the only substance that are being used in these products. We are increasingly seeing use of marijuana and other drugs used in this way. And so again, I'm not going to go into detail, but wanted to point out that there is use of other products in these devices. We have seen changes in the legal status, both at the federal level and the state level. Some of these finalizations of FDA rules have not been implemented yet, although they went into effect in August. And so there is age restriction. Other restrictions will be coming here in the next few years. Here in Nevada, we do have restricted sales to minors. They are not included in the Nevada Clean Indoor Air Act, so you may be seeing use of these products indoors where other combustible products are not allowed. Currently, there are no taxes on e-cigarettes beyond sales tax. That's something that we're looking at in this legislative session, to tax e-cigarettes. No limits on the flavors. So the fact that this is a draw for youth, we currently don't have any limitations on that. It is a public health concern. Again, it renormalizes that image of smoking, can be used in places where combustible cigarettes are not allowed, not as restricted on advertising. We see in studies that it increases dual use. People using not only combustible cigarettes, but e-cigarettes can be a gateway to combustible cigarette use. And we don't have a whole lot of information on the long-term effects. So with this, I will pass things over to Sandy to take the next step about how public health professionals and providers can use this information.
So welcome again. Are there any questions up to this point before we go into how we can help with the cessation part? Okay, so we'll move on. So in trying to get out there and help people actually quit, you know, there's cessation referral options, and we're going to go over some of those, but especially trying to get this into the electronic medical record system upon discharge, using those electronic discharge instructions to refer people for cessation. So that's something that we are really working on in Nevada. Creating policies to incorporate brief intervention in your practice. We're going to go over brief intervention. It takes 3 minutes. It's very quick. It should not take a lot of your time, but very important. And then the other referral sources, we have quick cards that you can just hand out to patients. There's magnets. Your health districts have lots of available material to get people referred to evidence-based cessation. And then lastly, we are going to also talk about what does the ICD-10 codes look like and the CTP codes. How can you actually be documenting, not only for us to make sure that we're documenting appropriately, but that we have data to support the toll of tobacco in Nevada. Next slide. So I think if you are a provider, if you are somebody who actually is billing for medical services, you are well aware of MARCA and MIPS. This has been coming down the pipe. I'm not an expert in this, but it really is about taking quality measures that you have to choose from, and then you will submit your data, and that data is going to actually impact your payments. And the payment adjustments are coming in 2019. However, the submission of this data, most practices have already had to choose, or the process of choosing the quality measures that they will be submitting for reimbursement. So some of part of this MARCA MIPS, I talked about the quality. So 60% of your score is going to be related to picking these quality measures. And then you have advancing care and information, and 25% of this is going to actually impact your payments. And then improvement activities. Once you identify areas that are low for you as far as your quality measures, you're going to have to show improvement activities. And then finally, the cost, the total score, is going to impact your reimbursement or have reimbursement taken away. So it's very, very powerful in the health world right now. But we want to show you that tobacco is one of those that you can choose and fairly easy to meet the mark. More information about MARCA and MIPS, because it does impact providers and hospitals, healthcare systems tremendously as far as how they're going to get paid in the future from CMS, which is the Center for Medicaid and Medicare Services. So I just want you to, I'm not going to go into this, but I want you to be aware that preventative care and screening, that tobacco use screening and cessation intervention is a way that you can meet this mark fairly easily. You just have to screen for patients 18 years and older, at least within the last 2 years of them coming to your practice, and then provide them either with cessation counseling intervention or refer them to cessation counseling intervention. So it's an easy mark to meet. ICD-10 has changed tremendously, and if you ever saw the ICD-9 codes before, they were very non-descriptive. I think there was roughly around 9,000 to 10,000 codes, and now with ICD-10s, there is over 60,000 codes. So what has happened is it has made this very much more descriptive when you are diagnosing somebody, and it's not just for tobacco, this is for everything. So originally we had one diagnosis code for tobacco, and that was for users, people who used and were dependent on nicotine. But as you can see now, we have all kinds of them. And I'm going to show you, we have a thing that we can hand out that actually is laminated with all of the codes that you're going to see here. So you're always welcome to contact us, and we'll be happy to send those to you. It's really, really important to use the correct code. Do not just use the unspecified code, because as we are looking at this data to see who's using what and how they're using and how the provider is identifying this, we want that very, very descriptive code. In the future, I'm hearing if you use codes that say unspecified, unless you have a really good reason why you could not specify, that code will be rejected for payment. Oh, I want to go back. Document diagnosis every single visit. So if they're there for asthma, but they also have nicotine dependence, they're a smoker, you should use it as a secondary diagnosis code every single time. because that is still part of their health diagnosis. And so what happens is people tend to just hit the primary diagnosis and forget about those underlying secondary diagnoses that may impact that primary. So document it every single visit. So there's specific codes for maternal and pregnancy for women who are smoking during pregnancy, and it's very specific, as you can see, by the trimester or after. The CPT codes that are available, these are the ones when you actually take, and you have to be a provider, meaning you have to be a physician, a DO, a mid-level in order to actually bill for these. But if you spend 3 to 10 minutes talking to your patient about quitting, then you can charge for that. I don't know what the reimbursement is. I know Medicare reimburses very little, but it's important that we're documenting that we are attempting to get them to quit, we're doing the counseling, and you can actually bill for that service. If you spend greater than 10 minutes, that is considered an intensive counseling session in your office, and you can bill for that. Prior to these CPT codes, there used to be what we call G codes, and those were specific to Medicare. Those have now been removed. You no longer have to do the G code for cessation counseling when you are billing. Here's the other part. For the first time, we have the ability now to actually document those people who are having health issues related to secondhand smoke. So if you had a patient who has chronic bronchitis and they've lived with their spouse who is a heavy smoker for a long period of time, and you have reasonable belief that chronic bronchitis is related to secondhand exposure, you can document that as a diagnosis code, and we encourage you to do that. We also encourage you to do that when it's occupational exposure. So those casino workers that you are having to come in and they've got chronic colds, chronic asthma, or asthma exacerbation, and their work environment is so heavy with secondhand smoke, we need this documented. We need this to be documented that their diagnosis, that primary diagnosis, is related to secondhand exposure. So again, use that as the secondary diagnosis. Pediatricians, you have opportunities to diagnose when you are dealing with a kid who has asthma, chronic ear infections, and you suspect that part of that is related to their secondhand exposure from their parents, their grandparents, wherever they're living, then document that. You can document that that is a secondary diagnosis, and you can counsel. You won't get paid, but you should be counseling the parents at that time. You can't use those counseling codes in pediatrics to actually charge for counseling of the parents because they're not the patient. So I'm just moving through some of the ICD-10 codes. There are lots of codes, and everything is descriptive now in ICD-10. So we just wanted to give you the additional things about poisoning, other effects that people have related to tobacco harm, including the one that says toxic effect of chewing tobacco, assault. So I'm not quite sure how we would see that, but they become very descriptive when it comes to ICD-10 codes. Brief intervention. So what is brief intervention? It's a simple ask, advise, and refer. So ask about their tobacco use, advise them to quit, and then refer them. What we do know is that when providers or people who are held high in education of health ask people about their tobacco use and advise them to quit, they are 30% more likely to take heed of that advisement than if their family is nagging them. So it's very, very important that you are an important part of this process. So again, 70% of smokers really do want to quit. And by having you ask, 30% of them are going to take that as an important step. Okay, asking. Just ask every patient every visit. You know, are you smoking? How much do you smoke? And make sure you do it every visit, because they might say no now, and then the next visit they're back to smoking. So you do want to ask every single visit. Once they have told you that they're tobacco using or e-cigarette using, advise them to quit in a non-judgmental way. We want you to let them know the health consequences, maybe what's already happening in their body that is related to this. Use those moments. They may not be ready to quit at that time, but it's that moment that you get to just really inform them as a health educator the risks of their continued tobacco use. If they determine that they do want to quit, then refer them to quitting. We have in Nevada, the Nevada Tobacco Quit Line. It's free. We're going to go a little bit more into that, but it's free. It's done with qualified counselors. These counselors have a bachelor's or master's degree. They're not somebody that is picked off the street to do sales. They are really qualified to actually do individual counseling. Remember that quitting often requires many attempts, 7 to 10. Now, we don't tell our patients that, oh, well, you know, this is only your first attempt and it's probably going to take 7 to 10. Some people quit after the first attempt. But just know that it's such a strong addiction that it's very difficult to have a first-time attempt at quitting be successful. What we do know from evidence-based is that counseling along with medications has the most successful quit rate. And you're going to hear all kinds of stories about what other people have used, but this is what is evidence-based as most successful, both the combination of medications and counseling. 1-800-QUIT-NOW does provide the counseling, and in some instances they can actually even provide free nicotine replacement therapy. So this is what the Nevada Tobacco Quit Line website looks like. This is where we want you to go and refer your patients. You can do this on the internet. Chrome and Firefox works best for this website. But you can enroll your patients right here. You will have to have permission from your patient to enroll them, but then the Quit Line takes it from there. They will contact the patient. They will make 3 attempts to call that patient. And if the patient at that time then says, no, I'm really not ready to quit, that's fine. Nobody's going to pressure them. They're not going to keep calling them back. They're going to say, can we send you some information that might be helpful? Or would you like us to call you back in 2 months? That's what they're going to do. Patients can also do their entire counseling online. So NevadaTobaccoQuitLine.com, they don't have to do it via telephone. They don't have to do all their counseling via telephone. They can actually do it online. And then they have programs where they'll send them motivational texts, messages through email to keep them motivated. What we do know about addiction, it's like every other addiction. And like we said, nicotine is as addictive as cocaine and heroin. So it's biological, it's psychological, and it's sociocultural. You have to hit all 3 components for success. Picking just one of those probably is not going to result in success. Again, this just goes over the evidence-based counseling and medications. That is what works best. On the Quit Line website, there are healthcare provider resources. We encourage you to look at these. They're very, very good. National Jewish Health Hospital in Denver, Colorado is where our Quit Line is referred to, and they are the leading respiratory hospital in the country, so they're very, very knowledgeable and very committed to Nevada for our Quit Line services. So when you refer to the Quit Line, like I said, you can do the web referral, you can just go right onto the website, you can do an e-referral. And we encourage you, if your electronic health system, record system, has the ability to put an e-referral directly in there, we would encourage you to contact National Jewish Health to get that set up. They've done this with many other providers, and they have the ability to help you, walk you through getting e-referrals set up right in your electronic system. And then you can do fax referrals. We have fax pads. contact us. We're happy to send them. They look like a diagnosis for radiology or lab slip, and you just do that and you fax it in. A little bit more about the Quit line. Quickly, they're open 13 hours or 16 hours a day. They take 13 years and older. They do, it's free. They have some preferred patients that will have the same counsel every time. So pregnant women, postpartum women, American Indian, have multiple languages that they can do. So there should not be a barrier to the Quit line. Our Quit line is fabulous, and there should be no barriers to people using our Quit line. Now, some insurance companies, some private insurance providers do have their own cessation services, so you may want to ask the patient to look into their own insurance provider cessation services. Quit cards. So we have the Quit cards. We are happy to send any of these. They're English on one side, Spanish on the other side. They're easy to hand out. We're happy to give those. We have magnets that look like little stop signs. But if you notice, we don't do anything that's really in bold red because we don't want this to be a judgment thing. We want to encourage people that it's important to quit. So you can get all of these materials from any one of the health departments or health districts. And our contact information is available on this slide. And again, this is free. Just let us know. We're happy to send you the coding. That way you can share it with providers and educate them on how to use that. Okay, I think I got through just in the nick of time. So any questions before we end our session today?
If you're on mute, just unmute yourselves with the icon in the lower left corner, or *6 if you're on telephone.
Hi, can you hear me?
Yes.
Hi, this is Judy Hunter, MIPS Society. And I just wanted to thank you so much for the presentation. It's so important, the information that you provided, all of the evidence, all of the data, and highlighting the quick one. Thank you so much for participating in Washington County. You guys are doing a great job. Thank you.
Thank you.
Any other questions? Okay, thanks everyone.
Thank you for joining us.
Thank you.